A 40-year-old man presenting with upper abdominal pain radiating to the back. Patient curled up in fetal position whenever he experienced the pain. He is known to have chronic dyspepsia. On examination, he was tachycardic with blood pressure of 90/60 millimeters of mercury. Serum lipase is 1,200 units per liter. Serum amylase is 1,000 units per liter. So the questions. Mention 4 differential diagnoses. What is the most likely diagnosis? What is the most appropriate test to assess severity? Mention 4 causes of the diagnosis. What are the complications? What are the prognostic scoring indices for the disease that you know? What is the link between gallstones and this disease? What are the indications? So the differentials, my 4 differentials are acute pancreatitis. The reasons being that the patient has epigastric pain radiating to the back with elevated serum lipase and amylase. My second differential is that of a perforated peptic ulcer disease. History of abdominal pain radiating to the back. There's a history of chronic dyspepsia in this patient. My third differential is acute cholecystitis, and the fourth is acute aortic dissection. The next question is, what is the most likely diagnosis? My most likely diagnosis is acute pancreatitis, for the reasons I had given earlier. Abdominal pain radiating to the back, chronic, the fetal position he curls up into when he's in pain, then elevated serum amylase and elevated serum lipase also. What is the most appropriate test to assess severity? That will be abdominal CT scan. And I just decided to explain at this point that the CT severity index was developed by Balthazar and colleagues, and it was done to help discriminate among mild, moderate, and severe forms of acute pancreatitis. And it focuses on the presence and degree of pancreatic inflammation and necrosis. So this slide just goes to show from the CT scan, based on the findings in the CT scan, a score is given. So if the pancreas is normal, score is 0. If there's intrinsic pancreatic abnormality with or without inflammatory changes in peripancreatic fat, a score of 2. And if there's a pancreatic or peripancreatic fluid collection or peripancreatic fat necrosis, the score of 4 is given. If no necrosis is seen, score of 0. If it's less than equals to 33% necrosis seen, score of 2. And if necrosis is more than 30%, score of 4 is given. Then if there are other extra pancreatic complications like pleural effusion, arthritis, vascular complications, score of 2 is given. And then based on the score, it's classified as either mild, moderate, or severe. Mention 4 causes of the diagnosis. The mnemonic I get smashed is used for possibility of acute pancreatitis. Okay, yeah, could be idiopathic, gallstones, alcohol, trauma, steroid, mumps or malignancy, could be autoimmune, scorpion skin, scorpion stings, hypertriglyceridemia, ERCP, drugs. And the drugs, mnemonic no idea is used to look out for the drugs that cause acute.
It's a more traumatic.
Okay, I was hearing sound at the background. Okay, N stands for NSAIDs, O is for others valproate, inflammatory bowel disease medications like sulfasalazine or azathioprine, diuretics like furosemide, um, estrogen, and some antibiotics that have been listed there. Okay, the complications of acute pancreatitis can either be local or systemic. For the local complications, we have acute peripancreatic collection, pancreatic cirrhosis, acute necrotic collection, walled off necrosis, or the pancreatic abscess. The systemic complications in the pulmonary system, there could be pleural effusion, atelectasis, or acute respiratory distress syndrome. The patients could have hypertension, hypovolemia, or pericardial effusion. Of course, acute pancreatitis is known to have some form of death-based fluid collection. Because of this problem, renal hypoperfusion could occur, and that will lead to oliguria and azotemia. It could be disseminated intravascular coagulation, and then other pathologies as listed there in the gastrointestinal system, and metabolic problems. Sudden blindness or Kuchar's retinopathy can also be seen in these patients. What are the prognostic scoring indices for the disease that you know? Okay, so there's Ransom, there's Glasgow, Atlanta criteria, the BISAP, and Apache. So I just run through them quickly. So Ransom criteria, it's done both on admission and then assessed 48 hours after. On admission, if the patient has if patients greater than 55 years, lymphocytosis greater than 16,000, AST levels greater than 250 international units per liter, glucose greater than 200 milligrams per dl, lactodehydrogenase of greater than 350 units per liter. A score of 1 is given to each. Okay, and if we have 3 or more factors present, then the patient has severe acute pancreatitis. 48 hours after, calcium is 8 milligrams per dl, hematocrit falls to greater than 10%, partial pressure of oxygen less than 60 millimeters of mercury, fluid sequestration of 6 liters. Okay, 3 or more scores indicate severe disease. And then the modified Glasgow, okay, the pancreatic mnemonic is used, where P stands for the partial pressure of oxygen, less than 60 millimeters of mercury, age greater than 55, neutrophilia greater than 15, calcium less than 2 millimoles per liter, renal function with urea greater than 16 millimoles per liter, enzymes, lactodehydrogenase greater than 600 units per liter, AST greater than 200 units per liter, albumin less than 32 grams per liter, and blood glucose, greater than 10 millimoles per liter. Okay, so the score is given one score to each, and then at admission at 48 hours, these are depending on the score, you can predict severity of disease and then possible outcome with respect to mortality. The Atlanta criteria, there's one that was done in 1992 and a recent one that was done in 2008. But the one in 1992 was a bit cumbersome and didn't address some issues. And so there was a revised Atlanta criteria in 2008. Okay, and revised Atlanta criteria based talked about the severity based on some criteria. So I said the pancreatitis was mild if there was no organ failure or no local or systemic complications, typically resolves in the first week. Moderate if there's transient organ failure less than equal to 48 hours and or local or systemic complications without persistent organ failure, and it's severe if there's a persistent organ failure that's lasting greater than 48 hours. What the revised Atlanta criteria also did was to define clearly um, the kind of collections based on the type of collection thing, the type of pancreatitis, we described it and also gave some CT scan contrast findings. Well, I didn't get that on my slide, but mm, for the acute pancreatic fluid collection, that is an acute interstitial edematous pancreatitis seen within 4 weeks with no necrosis. A pancreatic cirrhosis was referred to as an acute interstitial edematous pancreatitis and lasts more than 4 weeks after the onset. Acute necrotic collection, which is a severe, acute necrotic, which is seen in acute necrotizing pancreatitis, referred to as a severe form of pancreatitis, occurs less than 4 weeks after onset, and then the world of necrosis seen in acute necrotizing pancreatitis usually occurs more than 4 weeks after onset. Then the BSAP. BSAP is the bedside index of severity in acute pancreatitis, done bedside and is easily done, where we have low urine nitrogen of greater than 25 millimoles per liter, impaired mental status with GCS of less than 15, and then the systemic inflammatory response syndrome, if there's presence of any two criteria, okay, temperature greater than 38.5 or less than 35, heart rate greater than 90, respiratory rate greater than 20, a partial pressure of carbon dioxide less than 32 millimeters of mercury, white blood cell 12, greater than 12,000 or less than 4,000. Okay, for SARS, if there's presence of any two criteria, a score of 1 is given. Age greater than 60, and then presence of purification. Give a score of 1 to each. Score of greater than 3 indicates severity of the disease. And then the Apache 2 score is the most validated. Okay, so there are 12 parameters that are assessed in the Apache 2 score: temperature, mean arterial pressure, the heart rate, respiratory rate, partial pressure of oxygen. Yeah.
It will just round up. We have treated these questions. So that if there's any contribution. Dr. Blessing, get ready.
Okay, so the link between gallstones and the acute pancreatitis. Said that the risk of acute pancreatitis in patients with at least one gallstone less than 5 millimeters in diameter is 4-fold greater than that of patients with larger stones. So what happens if the gallstones become lodged in the pancreatic body? This causes pressure to build up distal to the stone, and this causes pancreatic enzymes to be activated, and then pancreatic enzymes to be activated. Indications for draining a pancreatic cirrhosis. So if there's compression of a large vessel clinically on CT scan, if there's gastric or duodenal outlet obstruction, stenosis of the common bile ducts, infected pancreatic cirrhosis, hemorrhage into pancreatic cirrhosis, a pancreatopleural fistula. These are the indications. And then there's the rule of 6. If the cirrhosis has lasted greater than 6 weeks, with no change in size or morphology after 6 weeks, size greater than 6 weeks and above, wall thickness of 6 meters above, this cyst is not likely to regress spontaneously, so should be drained. So that's the end of my presentation. Thank you. I welcome comments and contribution.
All right, thank you, Dr. Ipo, for presenting. The class is open for questions, clarifications. We've treated this acute pancreatitis, I think it's the 3rd or 4th time. So if you have any contributions or any clarifications we can make. And Dr. Iko, you can unshare your slide so that Dr. Blessing can share hers. Any questions, any clarifications? Dr. Esther is asking, Dr. Eko, are you hearing? Dr. Esther is asking, what are the CT features?
Okay. There are quite a number. I didn't really take notes. There are quite a lot. I didn't really take note of that, but I can add that to my slides. I just typed this thing over the night, so there are quite a lot, but I can add that to the slide, especially for the, I can add that to the slide.
Okay. Okay. You can add them. So Dr. Esther, so basically you want to check for pancreatic fluid collections and pancreatic necrosis. So you could get atrophy, dilated pancreatic duct, pancreatic calcifications. You can see all those on CT when you do a CT. So you have, when he adds it to the slide, you get the, and please share the slide as soon as possible too, so that people can follow.
Please, can you see my screen?
Yes, we can see your screen, but we're not seeing the presentation.
How about now?
Okay, yes, we can see it now.
Come. Juliet is just trying to tell me that I'm coming to work today. Come, let me rock praying for you. Come, come. What's the time? Please, Joel, I'm not come. You just did I bring out salt for you?
Okay. Dr. Atta, am I to go ahead, please? Hello?
Yeah, we can hear you.
Am I to go ahead? I didn't hear any feedback.
Your screen is,
yeah, I will go back to my screen just because I'm on the platform. I just wanted to know if I should go ahead.
Yeah, you can go ahead.
Okay. Can you see it now, please?
Yes, can see.
All right. Good morning, everyone. Good morning, our teachers and colleagues. I'll be taking practice question 4B, 2022, October. So the question reads, a 23-year-old people living with HIV/AIDS presents with skin lesion. So from the recall, what they said was they tried to describe a skin lesion that was on the face, towards the ear and all that. So I tried to look for a picture to suit into the description. So the STEM questions were: 1, describe the lesion. B, what's your diagnosis? C, what's the cause? D, what are the 4 types/classes? Then E, what's the histologic finding? List 3 differential diagnoses, mention the treatment options, then factors that would determine prognosis. So by way of describing the lesion, I don't know if you can see the screen clearly.
Yeah, we can see.
Okay, so basically, I think what they put in the recall was the one that was described around the face. So as with every dermatologic lesion, an attempt to describe based on location and based on description of the lesion. So it was described as violaceous papules and nodules around the ear, extending towards the neck. So the extent will be described, the features that we see will be described, and the way it's located. So different pictures had, if you have, depending on what picture that is brought for us, but for this one, we can describe it as violaceous papules, nodules around the ear, extending towards the jaw and around behind the back of the ears, because that's the only part that is visible. While the other one on the other side was like the distant part of the legs, the foot, the leg, the lower part of the limbs. So for clarity, to define some terms in dermatology, a violaceous lesion actually denotes a purplish or violet skin discoloration. And then in patients who have Kaposi sarcoma, the purplish or violaceous description is usually due to, it's a highly vascular tumor, or a highly vascular lesion. So usually due to the red blood cells and even deposition of hemosiderin that gives it that violaceous presentation. Even in the blacks is actually maybe quite visible. So there are papules. A papule is an elevated palpable skin lesion, which is less than 1 centimeter in diameter, while a nodule is an elevated solid palpable skin lesion greater than 1 centimeter in diameter. Next question says, what is the diagnosis? So the diagnosis is Kaposi sarcoma, can also be called Kaposi sarcoma-associated herpes virus. What is the cause? So it's actually a multicentric vascular tumor, which is caused by infection with the human herpes virus 8. Now, co-infection with things like HIV or use of immunosuppressants tend to make the cause more aggressive. So I added this here just in case in case they were, after mentioning the HHV8 and then they wanted to hear something else, you can just talk about the co-infection, making the cause quite aggressive. Now, what are the types of Kaposi sarcoma? So we have the classical Kaposi, we have the epidemic Kaposi, we have the endemic Kaposi, we have the iatrogenic Kaposi. Now, for the classical Kaposi, this is commonly seen in men who are greater than 60 years of age, of Mediterranean, of Eastern Europe, and Ashkenazi Jews ancestry. So it actually runs an indolent course. It's not as severe. It can take up to 15 to 20 years for a manifestation. And they are usually very small lesions and confined towards the lower limbs, extremities, and then visceral involvement in these individuals is quite low. So this is a picture of what I'm trying to describe for the classical lesion. Now, the other one is the endemic Kaposi. So endemic Kaposi is also termed AIDS-associated Kaposi sarcoma. This actually runs a more aggressive course than the classical one. It's less common in blacks, bisexual men, cigarette smokers, and gigolos, but it's more common in the affluent, college graduate, and homosexuals. This was actually a meta-analysis that was done while trying to, there was a time that there was a description when they are trying to classify. It was first initially classified into 5 before we now started talking about 4 classifications. So this was done in an attempt to identify the individuals who were more at risk and those who were less at risk. So this just is specific for the endemic Kaposi sarcoma. Now, it presents as multiple cutaneous lesions, and they are typically present on the face, on the trunk, can affect the visceral organs, the lymph nodes, and the mucosal region. Now, this is a description. This is what you see in endemic. So you can get to the mucosal surface, can affect the lymph nodes, can affect the face. So when you begin to see it on the face, affecting multiple organs and also having gastrointestinal manifestations, you'll be looking towards an epidemic Kaposi, in individuals who have AIDS. Now, the next one is iatrogenic Kaposi sarcoma. This is also known as immunosuppression-related Kaposi sarcoma. This type typically presents several years, about 15 to 30 months, after the average time after an organ transplant. It's about 15 to 30 months. So individuals with it's said that individuals with congenital immunodeficiencies like the Dijot syndrome and the others, they're actually, however, not at an increased risk of this condition. It can be fulminant, it can run different pathways. The course can be different. So it can be mild, it can be moderate, and it can be quite severe. And this depends on the degree of immunosuppression. And this is increasingly becoming common. This is increasingly becoming common, especially with the advent of kidney transplantation. And one of the drugs, particularly for kidney patients, whom we have actually seen and managed, is the use of the mammalian target of rapamycin inhibitors. So it appears to have an anti-Kaposi effect independent of its immunosuppressive effect. So when patients like this come down with it, we tend to change the medication, withdraw the other ones, and then we usually get some good results. Now, the last one is the endemic Kaposi sarcoma. Now, this occurs in Africa independent of HIV infections, and there are two types, the prepubertal lymphoadenopathic form and then the adult form. The lymphoadenopathic form predominantly occurs in children, involving the lymph nodes, may not have skin manifestation. So this may go on without if you don't have a high index of suspicion, it may be difficult to actually make a diagnosis of this particular one. While the adult form tends to resemble the classical one, which I said is usually, which I said runs an indolent course and tends to affect the lower extremities compared to the other systems. Now, what's the histologic finding? Classically, it is, or characteristically, it's described as having a sieve-like pattern with proliferation of the spindle cells, prominent slit-like vascular spaces, and extravasated blood cells. I tried to show a picture of it on the slide. You can see the first one, the A and the B, and then you can appreciate the extravasation of the blood vessels on the next one. So the next question is list 3 differential diagnoses. So I listed as many as possible. Bacillary angiomatosis will come first on our list. It's usually difficult to clinically distinguish this from Kaposi. However, when you do your biopsy, you'll see lobular vascular proliferations of the vessels lined by plump endothelial cells in patients who have bacillary angiomatosis. Then the hemangiomas are a very strong differential, both Mason's hemangioma and cavernous hemangioma. Another one is the seborrheic keratosis, in which individuals have like it just is like an outbreak. I don't know how they put it in dermatology, but they just have new onset lesions, like florid. Yes, you just have a new onset florid lesions that may resemble it. So it's also distinct. So this kind of patients, you want to check for you want to screen for malignancies in such patients. So that's seborrheic keratosis. Then you have the angiosarcoma, pyogenic granuloma, and then benign lymphangiendothelioma. So we can just pick 3 from this. I don't think they will need us to explain the reasons, but these are the ones that I found. So we want to mention the treatment options. Now, currently, there's no treatment to eradicate the HHV8. You actually treat based on the presentation, and the decision to take any treatment will vary because we already said that there were different forms, and those different forms had different associations. So it depends on what you're seeing. So the form of the KS, the presence of symptoms, and also the extent of disease. But generally speaking, I try to divide the treatment options into various forms. So it's easy for us to actually answer the questions if we get them. So you have the local therapies, you have the systemic therapies. Now for the local therapy, there's the cryotherapy using liquid nitrogen. You also have the laser therapy using laser photocoagulation. You also have topical therapy. So this imiquimod and then alitretinoin gel. So it's been shown that in the pathophysiologic mechanism of patients who have Kaposi sarcoma, there's a surge of interleukin 6 in them. And as a result of that, that's where the alitretinoin gel tends to come into play. So it's been shown that it can have an effect on this following this pathway. Now, the other one is the intralesional chemotherapy. This is usually done with the vinca alkaloids, either vincristine or vinblastine. Now, for the systemic therapies, it would also vary. It can be done, they can be done side by side, they can be done alone, like I said, depending on the extent of disease. So individuals who have the epidemic form, of course, you have to treat using highly active antiretroviral therapy endemic form, those we have to treat using the highly active retroviral therapy. Then the cytotoxic agents can also be used, particularly the liposomal doxorubicin, plaxicactel, and oral etoposide. You can also use immunomodulators. So it's believed to be highly angiogenic, and so factors angiogenic inhibitors. Recently, the pomalidomide was approved for, well, not too recent, but pomalidomide was approved for the use of patients who have Kaposi sarcoma. Other ones are the vascular endothelial growth factor inhibitors. That's the bevacizumab, which can also be used. Then tyrosine kinase have also been tried, but not necessarily with very good success rates. Now, the other therapy, we said local, we said systemic, and then radiation therapy. Radiation therapy is believed that Kaposi sarcoma is highly radiation sensitive, and so use of low voltage photons or electron beam radiotherapy. Now, what are the factors that influence prognosis? So it was quite difficult to get per se, but I just tried to divide it based on how we can answer. So the extent of the disease, of course, if the disease is widespread and compared to when it is local, prognosis will be worse. And if the disease is if it's associated with the use of immunosuppression, that when you stop the immunosuppression, there can be a regression. That can also have a better prognosis. If the disease is like I said, is locally seen, and then use of local therapies may also be a better prognosis. Then, like I said, for the one that is associated with the HIV, cigarette smoking has been found to have a protective effect. Sorry, that was a typo. That's the epidemic. That's supposed to be the epidemic. So for those who have the epidemic Kaposi sarcoma, cigarette smoking has been found to have a protective effect for them. And then visceral involvement. So if there's visceral involvement, the prognosis, of course, is worse. And then if there's no visceral involvement, prognosis is not as bad. I think I've tried to answer all the questions. I'm open to questions, clarifications, and contributions. Thank you very much.
Yeah, thank you, Dr. Blessing, for coming through. Okay, the class is open for contributions, questions, comments, clarification. Okay, Dr. Jafar was saying, okay, internal medicine made easy. Florence saying, impressive presentation. Dr. Ekele too is uploading your presentation. Okay, they're uploading your presentation. Okay, Dr. Esther, you can go ahead.
Good morning, our teachers. Good morning, colleagues and senior colleagues. Thank you, Dr. Daudu, for the beautiful and detailed presentation. I just want to make a few contributions for the histologic features, just like you mentioned, outside the spindle cells, the red blood cells, extravasation, we have what is called the promontory sign. It's also very important. You see the vessels grow into each other. So it's also a very positive sign for making diagnosis of Kaposi sarcoma, because there are other lesions that actually appear that way with sheets of spindle cells. And then to add to the differentials, yes, you gave a long list. Just to add some other common ones we see outside bacillary angiomatosis, molluscum contagiosum, monkeypox, dermatofibroma, and histoplasmosis are also important differentials. The treatment, when you're talking about SK, I think you're trying to remember the term eruptive. So eruptive seborrheic keratosis, when they usually seen in association with internal malignancy. Then for the poor prognostic features, so in addition to what you have said, for patients that present, depending on the stage the patient is presenting, so Kaposi appear in stages. So if they appear in the patch stage, the prognosis tend to be better. If the patient presents, they are already on ARVs as compared to those that are not on ARVs completely, because you find out that they just come with these lesions and we make diagnosis of HIV, and then trying to cancel them to commence ARVs, trying to treat the disease. The prognosis is usually bad because most of them will start going into denial and all that. But if patients are already on ARVs, I think the prognosis it's better. And also the time of presentation. So at the time of presentation, depending on the immune status of that patient as well, and then whether the patient presents early to the hospital. And then for systemic involvement, like you said, visceral involvement, but I think the pulmonary system, involvement of the respiratory system, has one of the worst prognosis. Once you begin to have pleural effusion, they start to desaturate and all that. It's a very bad prognostic future. Thank you so much.
Yeah,
thank you very much, Dr. Esther.
Dr. Esther, for the contribution. Any other contribution? Dr. Paul, saying skin biopsy can differentiate bacillary angiomatosis lesions. Okay, can differentiate bacillary angiomatosis lesions possess capillary proliferation and neutrophilic inflammation. In contrast, Kaposi sarcoma lesion display slit-like vascular spaces containing lymphoplasmacytic infiltrates. Acroangiodermatitis, also referred to as pseudo-Kaposi sarcoma, is also a differential. It shows uncommon vasonative lesion.
And in addition to that, they also have
the lower limbs. Okay, yeah, Dr. you want to say something?
Yeah, in addition to what he described, so we said bacillary angiomatosis may be difficult to. I'm in a meeting. May be difficult to distinguish, but on histology, there's also be lobular vascular perforations of the vessels where they are lined by plump endothelial cells, in addition to what he also said. So we can add that to the distinguishing features on histology.
Yeah. So and then he mentioned also pseudo-Kaposi.
That's the acroangiodermatitis.
One of the differential.
Yeah. Dr. Atta, you're breaking. Can't hear you.
Can you please walk us through the stages of cutaneous Kaposi? Okay, through the stages of cutaneous Kaposi sarcoma.
Hello, Dr. Atta.
Can you hear me? Can you hear me?
Yeah, I can hear you now.
Okay, can you, Dr. Jafar is asking, can you please walk us through the stages of cutaneous Kaposi sarcoma?
Okay, I can try.
Okay.
So I think just like Dr. Esther said, the stages, there are about 4 stages. Hello?
Yeah, go ahead. We're hearing.
Hello, can you hear me? Yes, so there are about 3 or 4 stages. The first one is the patch stage, where the lesions are described as flat. They are not raised above the surrounding skin. Then the next stage is the plaque stage, where the lesions are flat but are slightly raised. Then the next stage is the nodule stage, where at this point in time, they have turned into bumps on the skin, and they are now known as nodules. I think there's a the 8 clinical trial group, ACTG, that found they put a staging system, but that's the one I know. I don't know if there's any other one. Those stages are what I know. So the patch stage, the plaque stage, the nodule stage. I don't know if there's any other one.
Okay, any infectious disease specialist in the class, can you just help us out and give us a summary? Or any other person?
So, the dermatologist will be better here.
Okay.
Not really precious. Dermatologist.
Sorry,
Okay.
just to add, the one I was talking about, the ACTG group system, I think those ones they considered it was specific for the 8 associated Kaposi sarcoma, while this other classification, which there's no official accepted classification though, but that one divides it into the other one. But the 8 clinical trial group system, they is specific for the 8 associated and divides it into the extent of the tumor, the status of the immune system, that's the TIS, the extent of systemic illness. I think there are some other classification under that, but I can't give you that at this moment.
Okay, thank you, Dr. Blessing. Any other contribution? Yes.
Let's close the cast. I must appreciate the speaker, Dr. Daoud Blessing. She did a wonderful job, really. She did. And I also want to appreciate Dr. Esther for. Dr. Esther, do you want to say something? Your hand is up.
Okay, she has not brought it down since then, so I mean, she has. But I think she has finished her contribution.
Okay. I also must appreciate her for coming to fine-tune something. So thank you so much. Let me quickly add that for the prognosis, I know she mentioned the extremes of age. Extremes of age is also a poor prognosis. And one thing too is that once you notice one of the signals, one of the indications that the disease is become systemic and no longer localized is when you start see lesions in the palate. When you see that, that's a sign, it's a poor sign of worse prognosis. I think the others have been mentioned between Dr. Blessing and Dr. Esther. So thank you so much. It was quite a lucid presentation. So I think it was a lucid presentation. So thank you.